Hello, welcome to everyone joining us, and I'm really excited about this one today. I think it's going to be really interesting. Just for those of you who are new to IAPMD, International Association for Premenstrual Disorders, we were founded in 2013. We went fully global in 2018. Our website, IAPMD.org, is an absolute goldmine of information. We offer free peer support, free video support groups, there's treatment guidelines, there's everything you need to advocate on your journey. There's people you can talk to, online support groups. Please do take a look. It's also fantastic for providers as well. We have a provider section, and anyone that's here from a clinical background or a research background, we have the professional community. Please do join. We hold lots of webinars, and we're going to be running networking events. So do come along and learn. That's always fantastic. And I'm going to pass over to Dr. E and Hafsah.
Great. Thank you, Laura. Welcome, everyone. So I'm Tory Eisenlohr-Moul. I'm the Clinical Advisory Board Chair at IAPMD. I've been working with the organization since 2016. And today we're going to be talking to you about subtypes of trajectories of premenstrual disorders. And joining me to talk about this is my graduate student, Hafsah Tauseef. And she is really interested in these subtypes as well and how these things unfold over time. And in general, we, really hear patients when they say, that the criteria in general are a little bit strict and maybe don't encompass everyone's experience. So we're really trying to dig into that and understand what might be going on there. So, so this is us. My laboratory is called the Clarifying the Endocrinology of Acute Risk Lab, or the CLEAR Lab, at the University of Illinois at Chicago, where I'm an assistant professor of psychiatry. A few notes. We'll do our best to reduce jargon, but we don't usually give talks to patients, right? We usually give research talks to other scientists, to other people who expect us to use certain, $5 words, right, that are really sort of jargony. So it's very possible that we didn't catch some jargon and that we'll use a term that you're not familiar with. And so if you're not familiar with it, I'm sure someone else isn't too, and there's no shame in it. So please pop in the Q&A just the word with a question mark or the phrase with a question mark, and we'll do our best to circle back either in real time if we can catch it, or later on, and define things. Laura can also help out with that as the education and awareness director. She's kind of heard all that and is really good at explaining things. All right, then the other point I want to make is just that, I'm a licensed clinical psychologist. I specialize in premenstrual disorders. Hafsah is a clinical psychologist in training, and we have ethical guidelines that tell us that it's really not good for us to try to diagnose someone on the internet, treat someone on the internet, give them medical advice on the internet. And we're also, neither of us are physicians, but we are, I'm a licensed clinician and it's going to be a licensed clinician. So we're experts, but we really can't sort of give you personal feedback about your situation. All right, so an overview today. What is PMDD? What is PME? We're going to talk a little bit about that. Why is it important to study whether there might be subtypes of these premenstrual disorders? We're going to talk about a paper looking at possible timing-based types of PMDs. Then I'm going to talk a little bit about some of the different biological sensitivities that we think exist in PMDs as another way to think about types of sensitivity. And then we'll talk briefly about future directions, and we'll have a brief Q&A. So what is premenstrual dysphoric disorder? It's unique among disorders in that it is defined mostly by its timing. So it's defined relative to normal ovulation. So this is the normal menstrual cycle. You can see there's 28 days counting forward here in this line here. Starts with menses. Estrogen and progesterone are both low. Estrogen rises and peaks just before ovulation, before the egg is released, and then it falls. The egg is released, and then the shell that the egg came out of is called the corpus luteum, and that's where we get luteal phase down here. So the luteal phase, the shell that the egg comes out of during that time, pumps out a lot of hormones. It pumps out progesterone in the dotted line there, and then also in the solid line, a sort of second peak in estrogen. And then they both fall and menses starts again. So this menstrual cycle is really probably better described as an ovulatory cycle, and we'll talk about that a little bit later, but PMDD is defined as a reaction to ovulation. And what we see in premenstrual dysphoric disorder, which was created as a DSM-5 disorder in 2013, and then an ICD-11 disorder very recently, is that we see symptoms, once ovulation happens, we see symptoms start to show up in the luteal phase, rise throughout the luteal phase, and then peak around the onset of menses. And then the requirement is that they improve rapidly during menses. And then there needs to be a window of time during and after menses where symptoms are really minimal or gone. And this is the sort of prototypical way that this is the average, right? This is the average thing that we see in people with cyclical symptoms. About 5.5% of the US population that is ovulating naturally shows this pattern of symptoms when we just have them do daily ratings and we don't tell them why. So this is, you know, it's common, but it's not normal. The content of the disorder includes sort of these core emotional symptoms. So affective lability, which just means emotion swings or a lot of emotion changes, irritability or anger, interpersonal conflicts, depressed mood, feeling anxious. So one of these four needs to be present in something like the pattern that we just talked about, where it shows up between ovulation and menses and then improves with menses, then goes away at some point. At least one of those four needs to be present to make the diagnosis of premenstrual dysphoric disorder. And then you have to have 5 total of the symptoms listed here. So that could include changes in appetite, changes in energy, difficulties with thinking, decreased interest in things, feeling overwhelmed or out of control. And then physical symptoms can be part of it. Although I just want to note that if someone has primarily physical symptoms, that's really not what this diagnosis is about. This diagnosis is really about brain hormone sensitivity and the emotional and thinking and behavioral symptoms that result from that. So physical symptoms can be part of it, but if someone only has physical symptoms, then PMDD is not the right diagnosis. There needs to be distress or impairment. The symptom pattern has to be confirmed with daily ratings, because unfortunately we live in a society where you know, people assigned female at birth grow up being told that they all have PMS. And so there's a very strong bias toward, yes, I have PMS, especially if someone has a lot of emotional symptoms. It can be a really sort of like, oh yeah, that must be it, because all women have that and I must have that, right? So we have to confirm the diagnosis across 2 cycles using the daily ratings just to make sure that there actually is any pattern, because we don't want to overdiagnose it either. It can't be just an exacerbation of another disorder, although you can have another disorder on top of it, and in fact, most do. It's not attributable to the effects of a medical condition like endometriosis, a non-psychiatric medical condition, and it's not due to medication use. So, so if someone is taking oral contraceptives, for example, we could diagnose like a medication-induced mood disorder, but since it prevents ovulation, we can't diagnose PMDD. What is premenstrual exacerbation? The pattern of symptoms looks like this. In short, it can happen in any chronic disorder, especially we're thinking here about psychiatric symptoms. It can happen in any chronic disorder, but typically what we see is that the symptoms improve on a similar timeline to PMDD, but just they never fully resolve. So there's this sort of elevated background aspect of the symptoms. But in general, in research studies, I just want to note that we do require the same amount of change. So in theory, then this is sort of a more severe presentation overall in terms of the way somebody experiences the whole month. There's a lot of evidence that PME, again, can happen across many diagnoses. So it's transdiagnostic. That's a word that we use a lot. And what we mean is it happens across diagnoses. This hormone sensitivity can show up for someone with a mood disorder, for someone with bulimia, for someone with ADHD, et cetera, et cetera. It kind of doesn't discriminate based on the underlying diagnosis. But not all ovulating patients with a given disorder will have cyclical symptom changes. So you could be a person, for example, with chronic depression who does not have hormone sensitivity and just has, only has chronic depressive symptoms. So is there a distinction between PMDD and PME? You know, we want to sort of take all of this research that we've been doing to try to understand the differences and apply that. But there might be good reason to hold off on that. So is the distinction between PMDD and PME real? Probably not. You know, these hormone sensitivities are transdiagnostic. They can happen whether you have no background disorder, which probably is what PMDD is, or they can happen where you have a background disorder and that is sort of on top of that. And so your symptoms don't clear out entirely, but you get worse to the same degree. There are some studies, which I think I've alluded to in prior talks, showing that, you know, some of the PMDD treatments don't work as well for PME of depression. And we'll talk about that in a little bit. So, you know, there are some differences that we're still trying to understand. And we're trying to understand if that's symptom-based or if that's, differences in the symptom content, like anger versus depression, or if that's, really has something to do with a different trajectory or a different biology. We don't know. In the meantime, is the distinction useful? Until we have better subtyping based on the kind of research we're going to talk about today, I think so. My own personal belief is that people with PME of chronic disorders need a separate label because I think they need additional treatment on top of the cyclical symptom treatment. But getting really caught up in the distinction, I don't think is super useful. I think it can be helpful to understand what background disorders you might have. But if you're finding it distressing to try to understand the difference, I recommend that you just sort of step back and say, I have hormone sensitivity. So I just wanted to kind of give that disclaimer before we launch in. Why is it important to study subtypes of hormone sensitivity? Take it away, Hafsah.
Yeah, so I'm going to be talking about why it's important to study, and then I'll introduce the research that we've done so far. So next slide. Yeah, so what we see is that patients are actually not responding in the same way to treatments. We have 3 general treatment options for PMDD: SSRIs, oral contraceptives, and GnRH agonist. Fancy term, but it's just chemicals that kind of induce low levels of the hormones that go across the menstrual cycle. So it's similar to mimicking menopause. And what we see is that people just have a lot of variance in their responses. And some people don't respond at all, especially when we look at people with premenstrual exacerbation of depression. And what we're hoping to do is that maybe if we understand the different timings, we can figure out more personalized treatments and maybe make recommendations based on that. Yeah. So another thing that we notice is anecdotally, a lot of patients and research participants tell us that their symptoms are starting and stopping at different times, and that PMDD seems to be very stringent in its onset and offset in terms of their timing. And what we feel is that we might be missing individuals with this hormone sensitivity because of the way we currently understand PMDD. It's pretty rare for us to see people with pure PMDD. Usually there's different symptoms having different patterns, different on-off patterns. And that's why we thought this research would be really important to do. Yeah, so let's talk about what the research on the timings of subtypes look like. So first, I'm going to go ahead and orient you to how scientists think about the menstrual cycle. So in research studies, we actually flip the luteal and follicular phase. This is because we want participants to have the same hormonal meaning. So the luteal phase tends to have the same amount of days, typically 14 days, but the follicular phase has a lot of variety. So this is why we tend to flip it and orient it the way we have here. So you'll see starting from the left side, -15 is going to be ovulation. And then we go up to around day 1, which is menses onset. Yeah, so when do symptoms start? So you'll hear me say onset of timing. This is really just referring to when do symptoms actually start. So symptoms can start anytime after ovulation and last up to a few days into menses. So what we know is that symptom burden changes if patients are experiencing symptoms from for 12 to 14 days, so the entire luteal phase, versus when they're experiencing symptoms just 4 days before the menstrual cycle. And this has a lot of implications for the biological causes of the onset and offset. So offset timing means when do the symptoms actually turn off? So symptoms typically go away 3 days once menses start, right? There is some preliminary evidence to suggest that depressive symptoms take a longer time to go away. So this could be much later into the menstrual cycle and follicular phase. And this is what we refer to as offset timing. So what did the scientists hypothesize, which is what was our best educated guess as to what was going on? So we had 3 different hypotheses. The first one is broken down into 2 parts. The first one was that there's 2 possible time duration. There would be the 2-week duration, meaning that symptoms would start with ovulation and end with menses. Second, there would be another timing, which would be 1-week duration, which would start right before menses and end at menses. The final hypothesis was that symptoms of depression may have different timelines. So what we expected to see was that they would have this onset anywhere in the luteal phase, but they would take a lot longer to disappear once menstrual cycle had started, once the menses had started. So it would start anywhere in the luteal phase and take a while to go away once menses has started. So those were the 3 hypotheses. So how did the scientists do the study? So they recruited people from 2 different studies. So the 2 different studies they recruited from was the emotional interference and regulation study and kind of an internet-based cognitive behavioral therapy for PMDD. 74 people were eligible to participate, and the study was done in Germany, I should mention that. So how did they include people in the study? So people were included in the study if they had regular cycles, they were of reproductive age, so between 18 and 45, and that they had a PMDD diagnosis with prospective ratings. Scientists sometimes have to exclude people just to make sure that we can understand material, what's happening very clearly. So in this study, people were excluded in the study if they had medical or psychiatric conditions that might have made the results a little bit blurry or difficult to understand. Also, they excluded people who were on any medications that could have prevented us from seeing true symptoms. For example, if participants were taking birth control. So how did participants get filtered through this study? So first, we screened them for PMDD using a single time point survey. Then they were invited to come in and we had them fill out basic demographic information and make sure they meet our inclusion and exclusion criteria. Then we had them rate their symptoms for about 2 to 3 months to make sure that they met for PMDD. And we do this because, as Tory mentioned, there is a high false positive rate. So we really wanted to make sure that they met criteria. And what we considered for PMDD diagnosis was that 5 of those symptoms that Tory mentioned in the slide had that on-off pattern that we talked about. So these individuals were kept in the study and we did analyses on them. Okay, so what did we find? So before I describe what we found, I want to explain the structure of the graph. Tory, if you don't mind pointing. So here in the bottom x-axis, we have the days across the menstrual cycle. Menses onset is here, so you'll see that between -1 and 0. And ovulation is on -14, it's in the green bar. Each number on this line on the x-axis represents a day. So the purple phase is the luteal phase, where PMDD symptoms are thought to be most present. And in the red area, that is considered the follicular phase, where bleeding is supposed to start and where PMDD symptoms typically drop off. If I look at the y-axis, this is the average of daily symptom ratings. So lower means lower symptoms, and higher means higher symptoms. Now I'm going to describe the 3 most common symptom patterns that we found in this group. So the first pattern, this is the solid circle line. We call this the severe full luteal phase. About 17.5% of participants presented with this pattern. They had intense symptoms for the longest duration of times, but notably their symptoms turned off quickly. We often hear patients with this pattern describe this as half-life to refer to having symptoms for a full half of the month. The second pattern we found, this is the diamond dash line, is the severe premenstrual week late offset group. About 17.5% of participants presented with this pattern. They had really intense symptoms for 1 week prior to menses, but symptoms took a while to recover. Sadness and anxiety symptoms tend to follow this pattern. The rapid increase in symptoms during the last week before menses leads some patients to call this hell week. And the final pattern that we see is the open circle with dashed lines. This is the moderate premenstrual week. About 65% of participants presented with this pattern. They had moderate symptoms 1 week prior to menses, but symptoms turned off quickly. A majority of PMDD symptoms followed this pattern. Oh, and I'll let Tory take over the biological reasons for these subtypes.
Great. So one of the things that we're really excited to do is replicate these, so redo the study, make sure that we see something similar. I think we will, because it's exactly what I see in clinical practice, is that some people have this full luteal phase, some people have this sort of later onset, later offset. But we, as good scientists, we need to redo it in a new sample and make sure that we see these same groups again. And then the ultimate goal will be to understand how the biology might differ between these groups. And we're not quite there yet, of course, but I want to talk a little bit about where we might look or what we might think about when we're trying to think about what the different biologies might be. So first of all, the concept of brain hormone sensitivity is really important. The menstrual cycle and hormone levels are normal in premenstrual disorders, and that shows up in premenstrual dysphoric disorder, also people who have hormone sensitivity in the context of a chronic disorder, like with PME. And it doesn't seem to be the case that the hormones are metabolized or broken down differently between the groups either. So for a long time, scientists thought that might be the case. They spent a lot of time comparing the groups. And every once in a while, you would find a scientific paper where a group of scientists did find a small difference in hormone levels between people with PMDD and controls who didn't have the cyclical symptoms. But it wasn't ever repeatable. It just, you can always find one study that supports your idea, but we just, as a field, couldn't accumulate evidence that there was any difference in the hormone levels. So and then a series of experiments showed that the symptoms were actually, you could experimentally completely shut down the ovaries and then add back normal luteal phase levels of estrogen or progesterone, and the symptoms would show up in people with PMDD who have this history of daily ratings showing cyclical change, but not in controls. So the same levels of hormones cause symptoms in people with PMDD, didn't cause symptoms in people without PMDD. So what this suggests is that it's something to do with the brain. There's something not wrong with the hormones themselves, but rather with the way the hormones are being processed or talking to the brain. So what might be the biology of this abnormal effect of hormones in the brain? Well, we have a couple of really well fleshed out research areas that are strong, and then a bunch of other ideas that need to be explored. So the first area that I want to tell you about is poor serotonin activity in the luteal phase. In response to these normal cyclical hormone changes, the brain seems to have problems with that. Then I'm also going to talk about imbalanced GABA activity. These are both neurotransmitters or messenger chemicals in the brain. Imbalanced GABA activity in the brain. That's another area that's gotten a lot of work in this area. And then again, many other problems that that we probably don't even know about yet or aren't fully fleshed out. So serotonin. So what does serotonin do? Serotonin is really important for mood. So things like depression, sadness, but also irritability and even mania can be altered by serotonin. So it's really important for just that sort of basic baseline of your mood and how you're feeling. It's also important for thinking. So it's been related to concentration, learning, and memory. So, that can be affected. Ability to enjoy things, or the way that our brains process the value of different, an apple versus a piece of cake, for example. And then it also sometimes can be involved in physical symptoms as well. And that, is something that deserves more attention. In the healthy luteal phase brain, what we see is that estrogen and progesterone rise normally, and there are no serious changes in the way serotonin functions. And so we see normal mood, normal thinking, normal ability to enjoy things. This is a serotonin molecule over on the left, and it's, hanging out with estrogen and progesterone, and they're all buddies, and it's just fine. There's no problem. However, there are somewhere between 5 and 10 really strong studies, 5 that I cite regularly, showing that in the presence of high luteal phase estrogen and progesterone in PMDD, there are abnormal changes in the way serotonin is functioning and the levels of serotonin in different bodily fluids. So this really is thought to be responsible to some extent for a lot of people for the depression, the irritability, difficulty thinking, brain fog, also difficulty enjoying things. Nothing feels rewarding. I want the cake instead of the apple, all of that. So estrogen and progesterone in the context of a PMDD brain, for some reason that we don't fully understand yet, causes this poor serotonin activity that can, in theory, lead to all of these problems. Now I'm going to talk about GABA. This is another neurotransmitter or brain signaling chemical. This is the primary inhibitory, which just means slowing or stopping molecule in the brain. So it usually keeps things calm and in check. So the GABA, which is the molecule, and then the receptor that it works at, they're working normally to sort of keep things calm and in check. And part of the way that they work together to do that is that the GABA A receptor, where the GABA molecule acts, is really flexible, and it can be made out of lots of different puzzle pieces, basically. And these subunits or puzzle pieces can be rearranged really quickly when there are changes in hormones that can affect the signaling of GABA. So it's really adaptive, and it can sort of shuffle around, and it can turn into a version of itself that is sort of more or less sensitive to GABA based on what's needed, whether there's more or less of these hormones that change the GABA system. So in a luteal phase healthy brain, we see that these GABA metabolites or byproducts of progesterone show a normal luteal phase increase. And then the GABA A receptor adapts quickly, and all the puzzle pieces rearrange, and it sort of it slows things down so that this big increase. Remember, we talked about the corpus luteum spits out all of that progesterone in luteal phase. That big increase doesn't cause major problems in sort of the level of calmness or inhibitory control of your brain. So balance is maintained. There's a big change in progesterone and estrogen, but the GABA A receptor has your back. It's rearranging all those little puzzle pieces, and there's no problem. However, in luteal phase PMDD, one thing that we think might be happening, and we don't have really hard evidence for this yet in humans, but we do see it in animals. And so we're trying now in my lab to learn more about how this looks in humans. But what we think is happening is, again, there's this normal increase in progesterone and all of the GABA enhancing metabolites or the byproducts of progesterone. So there's normal increase in those, but instead of rearranging all the little puzzle pieces and adapting so that your brain can function normally despite this change, we think that in PMDD, or at least in animals who act like they have PMDD, this puzzle piece rearranging of the subunits doesn't happen correctly, or it happens really slowly. And so instead of your brain being able to adapt really quickly to this and counteract the luteal phase changes and function normally, suddenly there is either too much or too little GABA signaling. And so you can get irritability, anxiety, hypersomnia, where you sleep too much, depression. It can really throw things off kilter. So this is something that we think might be part of the luteal phase symptom profile too. So how do we treat this? Well, poor serotonin activity in the brain. It turns out SSRIs work really well and really fast to reverse this problem. They beat placebo after 24 hours. About 60 to 70, depending on who you ask, how you code response, do feel a lot better on SSRIs. They don't work for everyone. There is that 40% that don't respond, but they work really well. This is a really high response rate for a medication. So a lot of people think the SSRIs are being used inappropriately in PMDD, like, oh, you're just diagnosing me with depression when I really have PMDD. And that can happen. And I don't want to minimize or say that that doesn't happen. But if someone gives you an SSRI for PMDD, that's actually exactly what they should be starting with, because we know that counteracting that serotonin problem in the luteal phase is a big deal and a really useful for PMDD. Because it works so fast in PMDD, unlike in depression, we think that it's working by a slightly different serotonin mechanism. And we think that it can be, clinical trials show that it can be taken only in the luteal phase for a lot of people, and it's still effective. Other treatments have been worked on recently that are trying to focus on this imbalanced GABA activity. Unfortunately, there have been a lot of problems. So sopranolone, for example, is a molecule that was being developed by Azarina Pharma. Unfortunately, they didn't meet their primary trial endpoints, which has shut down the research program. However, I'm still hoping that someone else will be able to come along and pick this up and target this. But that is really an important treatment target that we still don't have a good medication for. I'm hoping we can develop one. And then if we don't have other things to try, and we tried several SSRIs, the next step is basically to just prevent normal ovulation. This doesn't mean that there's anything wrong with the hormones in PMDD, but it does suggest that, getting rid of this hormone flux can help us to prevent those brain reactions. If there's no hormone flux, then your brain doesn't have to worry about adapting. So to do this, we often use extended cycle contraceptives like a birth control pill, anything that suppresses ovulation, but especially drospirenone containing oral contraceptives like Yaz have clinical trials showing that they work better than a placebo. And they need to be given on an extended cycle. So they can't, because the brain in PMDD is sensitive to changes, they need to be given in a way that doesn't have that medication break once a month, where you can start to get hormone flux and then symptoms. GnRH analog injections or chemical menopause can be really difficult to access depending on where you are, but they can be a long-term solution for a lot of people. That also basically just induces a chemical menopause, and then we add stable hormones on top. So how do these relate to the subtypes? Well, I think that serotonin, a combination of the serotonin and GABA explanations are probably responsible for this full luteal phase phenotype. I really think that the two of those things are probably working together to drive that. I think that when it comes to the later offset phenotype, the delayed symptoms going away, especially for depression, I think that there's something else going on that really isn't being included in our research studies so far. So again, the review of evidence-based treatment, starts with SSRIs in the luteal phase or full cycle, oral contraceptives, and then we move to just preventing hormone flux. But again, a lot of people don't respond. And in particular, as I was saying, PME of depression doesn't seem to benefit from treatments that induce low estrogen and progesterone, or this sort of withdrawal hormone state, like very low levels. There's a couple of clinical trials showing that while oral contraceptives and GnRH analogs, which both produce these low, stable estrogen and progesterone levels, they beat placebo pretty consistently for PMDD, where it's very clearly on off. But when people have chronic depression that worsens around the onset of menses, it doesn't seem to work as well for that group of people. And so one thing that I'm working on right now, and that Hafsah as well, and some of the other grad students in my laboratory are working on, is we're doing experiments to try to understand whether the serotonin and GABA pathways that I talked about in the last section might be this sort of typical luteal phase hormone surge sensitivity. And so it's possible that this full luteal phase phenotype is really a result of progesterone sensitivity that has impacts on serotonin and the GABA signaling systems, as I talked about. But what I'm really interested in is this later offset where symptoms may take a lot longer to clear out, especially if the symptoms are mostly depressive, low mood, hopelessness, maybe even thoughts of self-harm. We're doing a series of clinical trials. We're on our third one now, looking at whether stabilizing and preventing this hormone withdrawal might help that latter group that has that late offset. And we don't know for sure yet, but the initial results are really interesting and promising. And so we're hoping to continue that work and maybe be able to talk about these different subtypes eventually in relation to different kinds of hormone sensitivity. All right, I'm going to pass it back over to Hafsah to talk about future directions and takeaways.
So what we really want you to take away from this, dwindling a lot of this down, is that even in patients with PMDD, we're just seeing a ton of variety where symptoms are appearing and disappearing. And this is really matching up with what patients and participants are telling us about their experiences. Scientists are really in their early stages of work to better understand these types of sensitivities and how they overlap. So we're hoping to do more research. Like I said, we're really excited about this line of work, and science kind of goes a little bit slower than we hope. I can see wonderful questions coming up in the chat, like, do you see this type of presentation? Do you see that type of presentation? Can you attribute one presentation to a particular thing? Unfortunately, we're still trying to learn a lot of this information at the moment. So what do we need to do to make that happen? Well, we need more people. We need diverse samples of people, and we need people with different psychiatric conditions so that we can understand all of what might be going on. But what our hope is, once we do all of this wonderful work, we're hoping to make it clinically relevant. So how do we do that? One, what do we hope to do with the research? One, we really hope that it really broadens our understanding of hormone sensitivity. We can see it when we talk to people, and we're hoping to capture it a little bit better. We really want to understand more definitively what are the biological causes of these, and then maybe offer treatments that may align with people's varying patterns. And like I said, we want to offer personalization of treatment. That's a really fancy word of saying, like, when someone comes with a particular presentation, we have good data to support that one type of treatment might be better than the other for them. So that's where we're headed. And we ask that everyone be patient with us as we go on this journey to find out what's going on. Next slide. Yeah, so again, it takes a lot of work to get a lot of this research done. We first want to thank the NIH for funding some of this study, and IAPMD for allowing us to talk about it and having the advocacy and working with us. And it takes a whole village of researchers to get some of this work out there. There's a ton of people from UNC Chapel Hill, and then there's a ton of people from UIC who have made this possible. Okay. And I'm going to hand it to Tory to do some of the Q&A now.
Fantastic. All right. Thank you so much, Hafsah. I'm going to bring up, sorry for the whiplash, everyone. We're just going to keep this up as we have our discussion because I think it might provide some useful scaffolding for what we'll talk about. So I just wanted to, it looks like we were able to respond to some of them in real time. I just wanted to highlight, I think these experiences from patients are so important, and I want to highlight them. So Haley says, that's such a shame, sopranolone, as I saw the research and got started on it. Only thing that has controlled my rage symptom. Yeah, so the intense anger and irritability, I think, is something that we expect to be related to both the serotonin problems that we talked about, but also those GABA problems. And sopranolone really acts at the GABA A receptor that we were talking about. So not that it doesn't change the molecule of GABA, but it changes it blocks basically one of the channels on the receptor where that molecule acts. So I was so excited about it, and I know a lot of patients were too, and I think we were all disappointed that didn't move forward. I'm really hoping that another larger pharmaceutical company will pick it up. But yeah, it doesn't surprise me that the rage symptom responded to that, and that's very, very interesting. And thank you for sharing that experience. So can different subtypes affect life post-op? So there's no research on this. First of all, there's no scientific research on that. Hypothetically, educated guess time, right? If I was going to make an educated guess about that, I would say, yeah, if people have this sort of full luteal phase sensitivity that seems to be driven by the surges in hormones that happen just around or just following ovulation, I would expect that those folks might have the hardest time when starting a new HRT regimen, because that's going to be an increase in estrogen or progesterone. Right. And if you're sensitive to that, just like what happens after ovulation, we would expect that to show up. Now, one good thing is that there are some really nice clinical trials and experimental studies showing that initial increase in symptoms when you increase a hormone dose or change a hormone dose, it can be very intense and very unpleasant and very difficult and even life-threatening. I mean, I think it's really important to take that seriously, but it typically only lasts a month. Now, there can be exceptions to that. There's always exceptions to anything, but in these samples we've studied, it really only lasts a month. So, it can make, I would say that if you have this surge sensitivity that really shows up post-ovulation, my educated guess would be that you would struggle with the increases in hormones when you're getting your HRT settled. But I would say, being patient is important, because it's very possible that it would be time limited for people. Again, talk to your doctor, not medical advice. All right. Has there been research exploring or showing fibromyalgia worsened? No, nothing on that great, important topic. I was just talking to my colleague Jess about how we need to study fatigue and pain in relation to PMDD more consistently. Nothing that I'm aware of, but great question, very important research topic. But I would say if any disorder that you have is likely to be made worse by the stress of having PMDD. And so I think, or of having hormone sensitivity broadly. So, not something we know, but seems possible. Is there a specific reason why the study was conducted in Germany? Yeah, so my postdoctoral fellow, then grad student, Katja Schmallenberger, who is an affiliate at IAPMD as well, worked with colleagues in Germany who had collected these data, and they had recruited them in such a way that we thought it was a really good fit for testing these subtypes. Is there any connection between autoimmunity and PMDD? Again, same answer. No research on this topic. Great question. Another hypothesis that I have, which is an educated guess, not based on research, but we are collecting data on this topic, is the idea that the perimenstrual group that has this later offset may be having a reaction in part to some of the immune changes that happen around the onset of menses. Seems like a possibility. If you have an immune system that is not functioning properly, seems very reasonable to, again, educated guess, to think that there's a possibility that could increase your risk for something like that late offset group. But again, we don't know. Is there it's methylation? So great question there. So Katja Schmallenberger is working on some of this. I know Emily Jacobs has worked on some of this. So the influence of especially COMT genetic polymorphisms, and I'm sure gene expression on sensitivity to estrogen fluctuations. I think that that's a really interesting question, but we really don't have good big genetic studies in premenstrual dysphoric disorder because of these issues of needing to diagnose with daily ratings, because the false positive rate is just unfortunately so high, where we just don't see any change in a lot of people who think that they have cyclical symptoms. So we don't know that, but interesting question. Is there any correlation between people with PMDD having severe hyperemesis gravidarum? I think, is that nausea? Yeah, okay, yeah, so nausea during pregnancy, I believe. Great question. Again, we don't know. Another great, we're just gonna write down all of these hypotheses and we're gonna see if we can work them in. That's something we could ask, right? We can ask people, did you experience, what degree of nausea did you experience during pregnancy? Did you talk to a doctor about your nausea during pregnancy because it was so severe that it was distressing to you? Great question. We can ask about that. And I think
that was included in our big survey. So we'll have to dig into that one and have a look.
Amazing. Great. We can look at that. If GABA signals too much, does that result in different symptoms than GABA signaling too little? So I'm really, really oversimplifying. It's not even really too much or too little broadly. It's specific brain areas probably. So it's really complicated. And yes, I think that's likely to be the case. And I think that it's really reasonable to expect that people who in certain brain areas are having too much GABA activity, maybe they would have too much stop, right? Too much slowing. That might be this sort of sleepy, fatigued, brain fog kind of thing. And maybe people who have too little, sort of not enough slow down and stop kind of molecule, maybe would be sort of anxious, can't fall asleep, irritable, very reasonable hypotheses, but not something that we really understand well, or not something that we've studied well to this point. It's also very difficult to study molecular signaling in the brain. You have to use a radioactive tracer and use something called a PET scan. It has to be very precise. It's very expensive, very difficult to do that work, especially in a group where you have to time things to the menstrual cycle. So really important work. I'm hoping that the technology improves so that it becomes more feasible to study some of these things, to see where in the brain they're happening, instead of just talking broadly about GABA, which is, again, really oversimplified. Okay, is there research on whether past trauma can affect timing? Yes, so one study that I did showed that people with a history of sexual trauma were more, sexual assault, were more likely to be sensitive around ovulation to changes in estrogen. So that was interesting. That's just one study though. We need to replicate that. There are some reasonable ways that could happen. Also, we know that trauma just in general makes symptoms bigger and more severe. So we would expect people with trauma to be more likely to be in the 17.5% groups, right? The full luteal phase or the perimenstrual severe. So that's kind of all we know about that. Trauma does not cause PMDD, by the way, but it can worsen it. Do we know why some PMDD sufferers are worse just before, during ovulation, as well as being bad before period? Yeah, I do see that sort of up and then down and then up again pattern in some of my patients and in some of my research participants. I think that's really fascinating. I don't know why that happens. Do people sort of have this sensitivity, but they're able to bounce back in the middle of the luteal phase, right? They're sort of able to, once the hormones are kind of high and stable for a few days in the luteal phase, they're able to sort of adjust and their brain can settle back in until the next big drop happens. And then there's sort of fires off again. That would be my educated guess, but we don't know. Do you ever see a pattern where mood symptoms are the worst at the end of menses, right before ovulation, and mid-luteal phase for 2 to 3 days? Same response. I think I've seen a lot of different patterns. It's very possible. Yeah, but we don't know. Struggling to get a diagnosis. Yes. And this is very important. One of the reasons I'm really passionate about this subtype work is that I think if you're in this late offset group, it's going to be harder for you to get a diagnosis. And that's not acceptable, right? I mean, I think it makes sense, but what I want to know is, okay, so is that really a different biology than PMDD? Do we need a new disorder? Do we need a new name for that? Is it a perimenstrual mood disorder? Or should we just expand the PMDD diagnosis or make a premenstrual exacerbation specifier? I don't know. I can't answer the question about what will help you specifically. I'm sorry, but I wish you a lot of luck with that. And I know that there's peer support that would be happy to speak with you on a more personal level about that. SSRIs losing their effectiveness over time, certainly plausible. The brain over time with SSRI use does change and does adapt. And it's certainly not outside of the realm of possibility that one could sort of respond, and then there could be further changes as you use SSRIs longer where they become less effective. I would expect maybe switching to a different SSRI or something like that. I think talking to a provider about that could be worthwhile. Why do some people with PMDD report a worsening of symptoms with a contraceptive pill? Great question. Inger Sundström Porma in, I believe, Sweden has done some work on this. Also, Andrea Rapkin at UCLA. I would point you to their work, and I know they've done some interviews and media interviews about their research, so I would encourage you to check them out. Again, Andrea Rapkin and Inger Sundström in Sweden. We don't know exactly why, but we do see brain differences in people who have a negative reaction to the pill. So there is something happening there and needs more research. So fibroids, I can't speak to your specific situation, but I will say like comorbidities, meaning that you not only have a premenstrual disorder, but you also have other disorders. That's what we mean by comorbidity, like co-occurring or happening at the same time. Any comorbidity is, of course, going to make PMDD or PME more difficult, right? It's harder to have two things than to have one. I think that's just sort of the nature of being a person with a body. So certainly if you're experiencing cyclical pain on top of a brain hormone sensitivity or in addition to, of course, I think that's a fairly straightforward thing to say that's going to be harder. But we don't know how those two things are connected or if they're connected. I think one thing that people have brought up is, is this later offset group just the group that has menstrual pain? Whether that's from endometriosis, dysmenorrhea, just general like more, harder cramps. It doesn't seem to be the reason for that when we control for that in our statistical models for these. It doesn't seem to be the reason, but we certainly could see that interacting with other symptoms and being a part of why someone feels worse or has more of a hard time during menses. So it's not fully accounting for this brain sensitivity that is taking longer to switch out, but all right. SSRI for 17-year-old girls safe. Can the lowest dose be used? So again, talk to a physician. Certainly can't give a medical opinion on this. I'm not an MD. I'm a clinical psychologist that specializes in the biology of premenstrual disorders. But yes, SSRIs are used in teenagers, certainly with good efficacy. There are I think it's usually a good idea just in general in the literature to have a psychotherapist as well in adolescence, just because there is so much stress, there's so much going on. So we want to be cautious and we want to have them sort of closely monitored by someone who they can feel comfortable sharing with. But in general, practice guidelines do suggest that SSRIs are effective in adolescents and safe.
I'm really going to quickly jump in as well. So if you are a parent of someone with PMDD, on Facebook, we have a Parents of PMDD support group and also a young person support group. So if your young person needs support, if you just search in IAPMD support on Facebook, you'll find it.
Thank you. Yeah, I get red and hot ears at night during PMDD and ovulation. Fascinating question. Not something I've ever heard of, but very possible. I think, we know that progesterone increases body temperature, and it seems plausible that if you have an adverse brain reaction to progesterone, maybe, again, educated guess, maybe somebody could actually experience that change in temperature in various ways. So that's an interesting idea. Fibromyalgia, have you seen patients with primarily physical symptoms being triggered and lifting in the PMS cycle? Yes. So some patients do have this, basically their cyclical symptoms are physical symptoms. It looks like Laura's saying something too as well. So do you know of a link between PMDD and other conditions like endometriosis and ADHD? The endometriosis, so the physical, I think that's a huge area of research that's just completely empty. No one has really looked at daily ratings of mood in the context of endometriosis to see, or in any gynecologic condition, to see whether if we recruit people for these gynecologic conditions like endometriosis, fibroids, what have you, do we see more PMDD than we would expect to see in people who don't have gynecologic disorders? That's a fascinating question, and we don't know the answer. The ADHD, I hypothesize, I have an educated guess that ADHD does show cyclical symptom changes for a lot of people who suffer from ADHD. And I have a large NIH grant being carried out with a colleague, Michelle Martel, in Kentucky, at University of Kentucky, to test that really comprehensively. So we're going to have an answer or closer to an answer on the ADHD question really soon. You said the late offset group has typically more depressive symptoms. If you found typical affective symptoms for the full luteal group. So this pattern tends to be predominantly, many people have the full luteal phase depression as well. So, there's always exceptions, but I would say in terms of mean levels, average levels, we see irritability, anxiety, interpersonal conflict, mood swings, things that feel, I think the way that patients describe it to me is sort of more out of character, more like, whoa, why am I so irritable? There's no reason for this, right? And really it's sort of a different character from chronic depression symptoms, for example. So I think it's because they tend to be these sort of high arousal things that other people might notice. I think that they have a different flavor. So that's what I would say. Typically it's these high arousal, like more upset as opposed to sad, right? So this sort of like, oh, right, this angry, upset, crying, more kind of outward showing of being upset. Okay. Is there any indication that people could have a combination of two patterns? Yes, absolutely. And I think that this is really common. And I have another grant to test some of these ideas with my colleague, Jess Peters, who is also on the clinical advisory board. And what we're going to do is we're going to recruit patients, naturally cycling patients who have borderline personality disorder, who tend to have all of these symptoms, depression, irritability, mood swings, all that. And what we think we're going to see is that a lot of them have both. So we're going to get hormones daily and symptoms daily and really try to see if we can correlate, identify these subtypes and see, because we think that what we're going to see is that a lot of patients with borderline personality disorder who ovulate are going to have 2 weeks of irritability, interpersonal conflict, distress, followed by, a week and a half to 2 weeks of severe depression and cognitive problems. And, at that point, what is left of the cycle, right? How are you going to diagnose that with daily ratings? I don't know if you can without the hormones. So I think that hopefully is going to lead to we're going to try to use the biomarkers to try to figure out how can we diagnose this link between these things without the daily ratings, or using a different method for the daily ratings. Because if you do have the combination of these two sensitivities, again, that could be your whole cycle, right? And then how are you going to get a diagnosis? And I really think this is happening to a lot of people, and this upsets me a lot. So, so I really want to figure out what we can do about that. All right. Thank you for this wonderful presentation. Oh, you're welcome. I have a question regarding mood issues during menstruation. It's known that bleeding reduces iron, and a drop in iron has been shown to impact mood. Yeah. So this is something that my colleague Daniela Stoyanik at UIC mentioned to me. No, we don't take iron loss into account during periods, but I think it's a really reasonable thing to look at. And we have a ton of banked blood from our participants in all of our studies. And we can look at that. I think it's a great idea. It's a great hypothesis that greater iron loss could be, part of what's going on for some people. Maybe that perimenstrual group has some of that going on. That's a great example of like other things that we haven't thought about. But on fluoxetine for over 10 years, recently started estrogen. So I can't speak to your situation, but I'm really glad that you're advocating for yourself and that sounds like you found a provider that's working with you, and that's amazing. I again can't talk about specific, how long is it going to take to work? I can't say that, but I will just say, a general word of advice. If you're making a hormone change to your hormone regimen, if anybody's making a hormone change, what we see in the clinical trials is that any hormone change, whether it's like, okay, I'm bumping my HRT up, or I'm bumping it down, or I'm switching to a different one, or I'm, adding progesterone or whatever, it seems logical to guess that there would be about a month where you could have increased symptoms following any change in hormones. Kind of doesn't matter, from what I can tell, what the change is. That the PMDD brain is just so sensitive to any change. It's just those puzzle pieces are not gonna rearrange the way they're supposed to. Serotonin is gonna get out of whack. Something's gonna, sort of be a problem for 3 weeks, a month. So, you probably, anytime you make a change, get the support you need and see if you can sort of, hang on through that first month and then evaluate how it's working. All right. Again, always talk to your doctor about that kind of thing. If I remember correctly, depression is the least likely symptom. Yeah. So here's a question. If we recruit PMDD based on offset, right? If we define PMDD based on offset of symptoms with menses, and we know that depression is the symptom that tends to last past menses, right? And then we define our PMDD group by that, of course, we're going to see less depression, right? So I think that could be an artifact of just the way that we've defined the PMDD diagnosis. And, irritability is really impairing and deserves attention. And maybe we needed to start there, right? But I think it could be kind of artificial that the people who have more predominantly depressive symptoms, maybe we're just not seeing them in our groups because we excluded them because their symptoms are lasting too long. And we say, oh, you don't have PMDD, it's lasting too long, right? So this is just a problem with, and we have to iterate and try to improve. I may have missed this. For people with primarily anxiety symptoms, what treatment is recommended? Regardless of your symptoms, the number one evidence-based thing to try is going to be SSRIs. If you have not tried them for whatever reason, please talk to your doctor about whether that is a safe and reasonable option for you, because it just works on so many systems, and it really is the best thing we have. I know it doesn't work for everyone, but it really is the best thing we have. But I think primarily anxiety, I think anytime it's sort of this high arousal, my guess is going to be, it's going to be something to do with serotonin or the GABA system. But there may be other things at play too. Any insights you can offer people who have experienced symptom onset just before ovulation? I mean, So there is some evidence that progesterone starts to rise a little bit before ovulation. There's something going on in the ovaries there that we don't like fully, or maybe it's the adrenals. I don't know. There's something going on there that we don't completely understand yet. So I would just file it under the same thing as the full luteal phase. 5-alpha reductase inhibitors. Yeah. Good point. Probably should have mentioned that. So finasteride, dutasteride are medications that typically were given for people with hormone-related cancers or prostate cancer and some other things. Also, sometimes I think male pattern baldness. I could be wrong about that. Again, not a physician, but I think it's used for some of those other things. But what it does is it prevents progesterone from being broken down into these things that we know trigger symptoms. So, and it prevents estrogen from sort of increasing the amount of progesterone in the brain, all of these things. So, even if it does create more progesterone, it can't be then broken down into the things that trigger PMDD or PME. So, there is one clinical trial showing that dutasteride benefits people with PMDD more than placebo. I know that I actually, at this conference I'm at, I just talked to someone who's like, yeah, we're recruiting more patients for the dutasteride study. So I know that people are still looking at this. And I know that they're interested in the mechanisms. The main limiting factor around this, well, there are two. One is that it's already licensed, it's already generic for other things, right? Which that's all I'll say about that. There can be some pharma things there, less interest when it's already generic. The other thing, which I think is more important, is that these medications definitely lead to birth defects, very serious birth defects. And when you're talking about giving a medication that we know is very teratogenic or leading to birth defects, very severe, can't be survived birth defects in many cases, people get anxious, doctors get anxious, right? I don't want to give something that I know can cause birth defects to a person of reproductive age who is ovulating, right? And sort of that is like by definition our target group with PMDD, right? So people get really nervous about that. Obviously, there are other things that we could do to make that okay, and it really should be up to the patient whether they want to accept that risk and how they want to manage that. But it does affect doctors' willingness, just because there are horror stories. Okay, a few more. Is it possible that treatment of other diseases can change what pattern? Yeah, I absolutely think so. And this is part of why the PME distinction, the PME, PMDD distinction can be useful, right? Like if it turns out that you have another disorder that is treatable with a different medication that is showing a PME pattern, if you treat that other disorder, it's very possible that what you end up with is just PMDD, right? And maybe that is helpful, right? To sort of treat this thing, come back and then see what you have left and see more clearly what's going to help with that. Very possible. So it doesn't always work that way, but I think it's a very real possibility. All right, someone talking about estrogen causing fatigue. Yeah, I mean, estrogen increases the synthesis of progesterone in the brain. So you can essentially get progesterone effects from estrogen. So that, progesterone is then metabolized to all of these GABAergic metabolites like allopregnanolone, which, depending on how your receptors are shaped, how those puzzle pieces are adapting or not, certainly possible to get, again, that sort of like overexcited brain, anxiety, irritability, or underexcited, fatigued, sad, etc. Not super well researched area, but hypothetically, yeah. Any research on PMDD in the context of perimenopause? No, but we have really been trying to push for that. And I know my colleague, Jennifer Gordon, at University of Regina in Canada. So she was trained in the same place I was in postdoc. She's brilliant and does really great work, Jennifer Gordon, on perimenopausal hormone sensitivity. And I think she did write a review paper recently about some of the possible links. And there's not good a lot, as far as I know. There's not a lot of like prospective daily rating research on that, but I think that it's really important, and I know that she's looking into it. Do symptoms that are primarily in the luteal phase end up happening through the month during perimenopause? Again, no data on this question. Super important question. How could we not know this, right? We absolutely, I mean, it's a tough thing to study, and it's gonna be a long longitudinal study to really do it right, but we need to know that. And I hope that Jennifer and others tackle that question. The area of PMDD, there's so few people studying it well using these daily ratings that are really trustworthy. And so there's a million questions like this that should be answered that just aren't yet, because there's just not enough labs. So we're working on it. All right, and then I'm just going to go ahead and answer this final question because there's just one. What about white blood cells? Yeah, so I think what you're referring to is the NIH finding that neurons grown from the genetic material taken from white blood cells of people with PMDD versus controls. I think that's what you're talking about. They show overall greater expression of genes, or lesser expression, I can't remember, changes in the expression of genes that are related to cellular processing of estrogen and progesterone. And so that may be part of how we then get problems with serotonin, problems with GABA, right? That could be part of the sort of underlying abnormal response. But one thing that I will say about that paper is that what they didn't find was gene expression differences in response to a change in estrogen or progesterone. It was instead just sort of baseline differences. So it's something that's there all the time, which is really interesting. And again, it's not a separate mechanism to what I've been talking about. It would be an underlying thing that might help us follow the pathway to try to figure out how, the gene expression is different, and then how do we get to these differences in the proteins that we've been measuring, like serotonin and GABA A receptor subunits or whatever, what have you. So I think these are all compatible potentially mechanisms, and we're just sort of studying them at different levels: genes, cells, and then eventually behavior or emotional symptoms at the top. So we need to replicate that study and also figure out whether there might be differences in gene expression or neuron responses, in vitro, like they did in people with, for example, late offset depression versus periovulatory onset symptoms. All right, I think that's going to be it for now. Thank you so much for coming, and I hope that you learned something, and I hope you know that we really care and we want to get this right, but it's really hard work to do, and there's not very many of us. So if you know somebody who's training to be a scientist, maybe turn them on to PMDD or PME as a research area, because we just desperately need more people who are interested in training to be scientists in this area, to be matched up with people like me who want to train scientists in this area, so we can have lots of different labs working on this instead of like 4. We need that. So thank you, everybody. And yeah,
I think this has been our highest turnout on a webinar. So well done to you two.
Great.
Thank you so much to everyone for coming, and thank you so much for Hafsah and Dr. E. You've been amazing.
Yeah.
Really, really interesting. Thank you so much. Take care, everyone. Have a good evening, good day. Bye.